But I think a critical element here is not to feel like you're dropping the ball or making the conditions of the patients worse simply because you're frustrated because you cannot organize it the way you would if you had multiple systems arriving, the ambulance EMS, the fire departments, the air evacs, and so on and so forth. So somehow we've got to realize that what we're doing is the best we can with what we have, and that is the best we can do. However, we could group these patients into these categories. Walking woundeds. As people are out there asking if everybody's okay, you can take charge, formulate this medical control on scene, even as a Good Samaritan or as a volunteer, and say, who wants to help? And so you collect those individuals, and then you say, here's what we're going to do. In this section over here, we're going to have our walking woundeds. I want them to sit on the ground because they could get worse. Their slight stomach ache right now could be internal bleeding, and they could actually go into hypovolemic shock and become a priority. So I want them to be categorized over here. They need to be seen. It's just that they're walking wounded. They're potentially not injured that badly. They might transport, they might not, but let's put them over here so we can keep an eye on them. The next section is going to be the second priorities. These are the individuals that do have abdominal pain. They might be pale, cool, sweaty, but they're not decreased in their level of consciousness. They might just be fear-induced, psychosomatic shock. These people might have a fracture, a serious cut, but the bleeding is controlled. These individuals need to be seen and transported, but they're not critical. They're not the first to leave. But we're going to want to have them in one section over here so that we can keep an eye on them and watch to see if they graduate to priority 1 or the next to goes. Then you've got your priority 1s. These are individuals that are unconscious but breathing, obviously in shock. They have multiple fractures of long bones. They have possibly they are paralyzed, or have some semi-paralysis. These are individuals that might die. In the triage scenario, they stop breathing on their own. They are now a black tag. Now this is extremely, extremely touchy. I know this is touchy. It is so difficult as a rescuer to know that if you had one-on-one time with a patient, that you could probably give them rescue breathing and artificial chest compressions and sustain life for another 6 minutes, 8 minutes, 10 minutes, or sustainability, or at least the ability to revive them with an AED and with ACLS, advanced cardiac life support. But because there's multiple patients, because there's chaos, they stop breathing, they get brought to the morgue, the makeshift morgue, and are no longer worked on. This is probably one of the most difficult situations that was faced in wartime. Triage, of course, is a valuable tool in trying to figure out what soldiers that are injured are going to be considered dead versus those who are viable. We have limited resources. And when a person stops breathing and they lose their pulse, they're clinically dead. But in triage, if they can't breathe on their own, it means that they are so critically injured that they probably will graduate to dead within a short amount of time. If we had enough resources that we could allocate to them, we would do so, as long as we were not neglecting the others. But in a triage situation, it's because there's more patients than we have healthcare providers or rescuers. And that is one of the most difficult situations to deal with, is categorizing people who are not breathing, not moving, into the dead category. But that is how triage works. That's the formula that works for triage, so that we can pay attention to those that are viable, that we can contribute to, that we can give our resources to help them. Remember that if you do have to make a makeshift morgue, and there will be people that have obvious signs of morbidity, decapitation, open skull fractures, eviscerations, and no pulse, no movement, no breathing. These people are obviously, they're dead. The makeshift morgue should not be a place where people are gawking. This should not be the location where people are passing by on a regular basis or stepping over the bodies. This makeshift morgue, there's no critical treatment going on there. Sure, we could go back there, send another volunteer back there to double check to make sure none of them have revived and started breathing. That's always a good idea. But they should have stuff covering their faces at least and their major wounds. Give them dignity in this time of death. Have people standing around that section to make sure no one is stealing or pillaging off from the bodies. It's hard to understand. It's hard to believe that this would happen, but it would. And we must treat those bodies in a dignified way, in a respectful way. And then focusing the majority of our volunteer and trained personnel onto the viables or hopefully viables. When emergency medical services arrive, this is the professional level now, and we actually have someone who's ready to take scene control. The person who was assuming that medical control, that scene control, it's going to be vital that they are notified immediately, and then they go to that person who's going to be assuming scene command, and then they communicate in as concise a way as possible what is going on, how many patients they have in each category. We have 12 priority 1s, 10 priority 2s, and we have 22 walking woundeds. The priority 1s are in this section. They are being maintained, reevaluated, and treated over here. The yellow category or priority 2 category is over here. They're being maintained and revisited often. And reassessed for priority changes, and the walking wounded are over here, and our makeshift morgue is over here. We have a 10 count of dead. That scene command person will probably set up a landing zone for the helicopter. They will be setting up an arrival location for ambulances to come in and take the next person, the next priority out in an organized, triaged manner. They will probably come with triage tags and start the formal triaging by affixing tags to people with basic information and making sure they're reprioritized. They will then probably issue the vests to the different officers so that there is more of a professional and organized manner to who it is you need to report to and help. But by all means, the volunteer system can still be a service in many cases to scene command. It's never easy to have a multi-casualty incident, especially when something comes out of nowhere like this desert race accident. We do the best we can. We realize that when there's a delay of over an hour for emergency medical services, remember, in EMS and in trauma care, there is such a thing called the golden hour. This is the time from the incident to the time we actually fix the underlying problems that affords this patient the best chance of survival and recovery. When care does not arrive for over an hour, the golden hour is gone. It is one of the worst case scenarios you can imagine. And it becomes more of a wilderness medicine, which in wilderness medicine, there's not much room for treating cardiac arrest. It's looking at those individuals who we can manage, we can care for, to give them the best chance of survival. I hope this was helpful. If you have any questions, comments, please send them to royonrescue@gmail.com. Keep the questions coming. And until next time, go forth and rescue. This is Roy from Roy on Rescue. Have a great day.